All right, we're going to talk today about saber-toothed tigers. So I know you've all been dying to understand how saber-toothed tigers have anything to do with undergraduate nursing curriculum, but, well, I'm here to tell you. So I used to work with this cardiologist named Nelson Wolfe, one of my favorite people in the world. He had an expression that 10,000 years ago, your biggest chance of dying was getting eaten by a saber-toothed tiger. So we had evolved to make sure that our bodies could stop bleeding right away. So we have this fancy clotting system, and the platelets get involved, and then the clotting proteins get laid down and traps the red blood cells, and a red blood clot forms, and we don't bleed to death. Great. Well, today, our biggest chance, one of our biggest chances of dying is not getting eaten by a saber-toothed tiger, but rather heart attacks and strokes. And so part of our job in medicine nowadays is to poison our clotting system and make it harder for our blood to clot. And that's the beginning of this lecture. So first, you have to take an oath, all right? That oath goes like this. I state your name. On my honor as a nursing student, do hereby promise to never use the phrases blood thinner or prevents blood clots so long as I shall live, because I'm better than that. So help me, Florence Nightingale. All right, take this oath and let's move on. So again, there are no more saber-toothed tigers. We now need a way to prevent blood from clotting as easily. And there are plenty of dumb ways to die. We all know that from other lessons that we've had in undergraduate programs. But venous thromboembolism, or VTE, is a huge leading cause of death in hospitalized patients. 60,000 to 100,000 people in the U.S. die from VTE every year, so says the CDC. So remember, there are two pathways. There's the extrinsic pathway and the intrinsic pathway. So the extrinsic pathway is what happens when trauma occurs. Your arm gets chopped off, and in order to stop your body from bleeding, it goes through this fancy clotting factor. And the intrinsic pathway is the way that your body repairs damage to the endothelial lining of the vessel, of the arterioles, and that involves thrombin and factor VII. And you know what? This is way too complicated. So, nice if you know it, but here's what you really need to know. The vessel breaks, something happens, whether it's an internal thing that happens to the endothelial lining or whether the vessel gets severed. The first thing that happens is platelets show up, and the platelets get together and they throw a party, and then the fibrin appears, because fibrin never wants to miss a good party, and then the clot forms with red blood cells getting trapped in there, and eventually, as the vessel heals itself, then clot retraction occurs and you get better. So there are different drugs that affect clotting. There are antiplatelet agents, there are anticoagulants, there's direct thrombin inhibitors and other novel anticoagulants, and then there are thrombolytic agents as well that help your body to dissolve clot. So let's start by talking about the antiplatelet agents. Many of the patients that we take care of, particularly in the coronary artery disease, cerebrovascular disease, and peripheral vascular disease worlds, have antiplatelet drugs. So those drugs are used to prevent the platelets from aggregating. Remember, that's the first step in the clotting cascade. So when we prevent those platelets from aggregating together, it makes it much harder for the body to go through the rest of the clotting the rest of the clotting process, including the protein cascade, etc. So the way antiplatelet agents work is kind of complicated. There are all these receptors on the platelet, it turns out, that are amenable to different medications. So the thromboxane A2, you probably remember from pharmacology, thromboxane A2 has something to do with aspirin. And then there are other receptors called the ADP receptors that are on the surface of the platelet, and medicines like PLAVIX or CLOPIDOGREL work there. And then there's also this funny thing over here called the glycoprotein 2B3A receptor. And those GP2B3A receptor inhibitors are another site of action, or another site that we can poison in order to prevent blood from clotting as easily, or to prevent the platelets from aggregating as much. So we're going to just break that down into a simpler thing. It's not important that you understand the thromboxane A2 and the ADP receptor and the glycoprotein 2B3A receptor and what's all special about them. It doesn't matter. As far as we're concerned, they're just 3 different receptors. And so aspirin, as I said earlier, works on that thromboxane A2. Again, unimportant. I just want you to have a frame of reference to understand that that's a different site of action than PLAVIX is. The dosage for aspirin is somewhere between 50 and 325 milligrams daily, usually. I can tell you that all of the stroke research that's been done, the most favorable outcomes are with a dose of aspirin that we don't even have in this country, and that's 50 milligrams a day. There are plenty of studies that have shown that we have better outcomes with less intracerebral hemorrhage when we use that 50 milligram dose a day. In fact, it seems that the smaller the aspirin dose you get, the safer it is. And as I said, the lowest dose is really 50 milligrams, but you have to go to Europe if you want to take that dose. So here it's 81 milligrams, not 80 milligrams, 81 milligrams. So there are adverse effects from aspirin. Of course, GI bleeding can happen because it is a gastric irritant. But you notice that when you're on aspirin, you bruise more easily, and when you cut yourself, you bleed more easily. Well, that just means it's working, right? So what are the laboratory tests that we use to monitor aspirin? Well, it's a little bit of a trick question because we don't actually have a laboratory test to monitor your effects from aspirin. If we really wanted to, we could stick a knife in your arm and count the number of seconds it takes until the bleeding stops. Well, that's actually a test. It's called the bleeding time, and it's not a knife, but they use a little lancet. They stab you in the arm with it, and then they keep wiping the blood away until the bleeding stops, and they count that time, and that's your bleeding time. We don't really use that test very much. So we know that when you take an aspirin, it binds irreversibly with all the platelets in the body. Oh, and by the way, how long do platelets live in the body? Remember that? Somewhere in the neighborhood of 7 to 10 days. Well, that's about how long you need to stop this medicine before surgery. All right. Clopidogrel or PLAVIX is another antiplatelet agent. So why do we sometimes use PLAVIX and aspirin together? Well, if they're both antiplatelet agents, how can that be useful? Well, it's useful because they hit 2 different receptors, right? We talked about the thromboxane A2 receptor with aspirin, and now the ADP receptor is the one that we're going to hit with the PLAVIX. So clopidogrel has a once daily dosing of 75 milligrams. Again, this also binds irreversibly for the life of the platelet. You should also know that in addition to the 75 milligram daily dosing, we do have loading doses. And so sometimes we load patients with 600 milligrams of clopidogrel before angioplasty and stenting and things like that. Or when we're switching from another antiplatelet agent to PLAVIX, sometimes, again, we load that patient with 600 milligrams or sometimes 300 milligrams of clopidogrel. But the usual daily dosing is about 75 milligrams daily. One other little interesting thing is that it may be that about 5% of patients who get PLAVIX are non-responders. And the reason for that is that PLAVIX is not actually a medicine. It is a prodrug. And if you remember back to pharmacology, you remember that a prodrug is an agent that is given, and in the body then it is converted to the active drug. And in the case of about 5% of people who take PLAVIX, they take that as a prodrug, and it does not get converted in the body. About 5% of us can't make that conversion, so PLAVIX doesn't work for those people. Just a little interesting sidebar. So the interesting thing about PLAVIX is that it is not a gastric irritant. Aspirin can eat a hole in your stomach. PLAVIX doesn't, but it also makes it likely that you could have more bleeding, more bruising, etc. And this is another medicine that needs to be stopped 7 to 10 days before surgery. Just like aspirin, there's really no lab that we do to monitor PLAVIX effectiveness or efficacy. But if we need to understand, what somebody's risk of bleeding is, then we can do that bleeding test, the bleeding time, and see how long it takes for their blood to clot. Finally, acting on the platelets are GP2B3A inhibitors. These we typically use in the cath lab, and these are super aggressive drugs that poison the platelets so that they are not able to clump together and form clot. It's very useful with coronary artery stenting or other coronary interventions. And those medicines include integralin, ReoPro, and Aggrastat. They have weird names that we won't even bother to learn as the drug names. Contraindications are anybody who's had major surgery within 6 weeks, anybody with a stroke within 30 days, any hemorrhagic stroke history, bleeding disorders, or if your platelet count is less than 100,000. So this is interesting too. You should know that antiplatelet drugs like aspirin, PLAVIX, and integralin, for instance, we do not measure their effectiveness by the platelet count. The platelet count has nothing to do with it. There's going to be the same number of platelets running around in your bloodstream whether you get PLAVIX or not. The PLAVIX or the GP2B3A inhibitor or aspirin or whatever simply attaches to the platelet, rendering it ineffective. So unlike the other platelet agents, however, the GP2B3A inhibitors do not bind irreversibly with the platelet. Once the medicine wears off, the platelets go back to their full active duty and their regular functioning. No labs to really monitor with these either. So those are the antiplatelet agents. Now we're going to talk about protein binding, because that's an important consideration when we talk about our first anticoagulant. So I want you to understand this pharmacologic concept called protein binding. What happens is you take a drug and it gets into your gut, and in the gut it gets released into the plasma. All right, so this drug then goes into the plasma, and what's in the plasma but protein, right? So albumin being the most prevalent protein in the blood, binds to some of these drug pieces, all right? And as it binds to those, they are no longer active in the blood. So for instance, you take an antibiotic, and that antibiotic binds with the plasma. The pieces of that antibiotic that are bound to the plasma protein are not biologically active. The only ones that are the free-floating drug pieces, and they are biologically active. So a certain number of these drug molecules have to be bound to the plasma and have to saturate the plasma, and whatever's left over then can be biologically active. Does that make sense? So the ones that are in the little blocks here, we'll say, are already protein bound. They are inert. They can't do anything except take up space, so that whatever ones are left over and floating free in the plasma are biologically active. So that's easy to understand. But now let's add a new drug. Let's add another drug like warfarin, which we're going to talk about soon. And now when we add the warfarin in, it gets absorbed into the plasma, and some of them displace the first drug that was taken in, and now that first drug is much more biologically available, and everything changes now. We're going to get to that when we talk about protein binding with a drug called warfarin. All right, so protein binding means that absorbed drugs are bound to plasma proteins, which renders those protein-bound drugs inert. However, the rest of the drug that's given that doesn't have any protein to bind to makes those free-floating molecules biologically active. Then when we add a new protein-bound drug, it displaces some of those old protein-bound drugs, making that first agent more biologically available. And therefore, when we add a protein-bound drug to another protein-bound drug regimen, then dosage adjustments of both drugs have to be made. And that's very, very common when we have warfarin and then we add an antibiotic. So let's talk about warfarin, and we'll start our discussion of anticoagulants with that. So first, who needs anticoagulants? Well, antiplatelet agents that we just talked about are for preventing heart attack and stroke, and for dealing with little vascular issues, right? They are not effective at preventing blood clots in the legs, for instance. They're not useful in preventing DVT or, as a result, pulmonary embolism. So we need anticoagulants. And remember, instead of working at this level on the platelets, they work at this level on the fibrin and the fibrin clot formation. They're useful during acute coronary syndromes. They're useful during and after vascular procedures. During surgery, like open heart surgery, we use anticoagulants, and then we use them following TPA after we dissolve clots. They're useful as well. Those people who are at risk for clot forming, we want to use a prophylactic anticoagulant. And so for hospitalized patients, usually after surgery, and people who are medically vulnerable. So we're going to talk about all those people as we go through this. So the first, I lied to you. I said we were going to talk about warfarin first, but I lied. Sorry. We're going to talk about heparin first. The first anticoagulant that was really invented was this heparin stuff. And heparin is this big, ugly, unruly molecule, and it's giant and it's hard to navigate. There's like 7 different places that on the molecule that are responsible for the blood clot or for the blood. I almost said blood thinning, but we're not allowed to say that. But there's about 7 different places on this molecule that are responsible for the anticoagulant effect. That makes it really hard to manage. We use it because we can, and it's cheap. And we know how to use it because we've been using it for, 60 years. You get an immediate effect when we bolus people with it. It's highly protein bound. And therefore, if we mix it with another medicine, we may need to adjust the dose. It is reversible with a medicine called protamine. And so that's useful if somebody is bleeding to death and we need to reverse the heparin right away. Or during open heart surgery, they give a huge bolus of heparin. And when you're coming off pump, after you get off pump, then they reverse that with protamine so that you don't bleed to death as you recover. There is such a thing with heparin as heparin-induced thrombocytopenia. So there's the number of people who get this is very low, but it's not 0. So we monitor for it. And the definition of thrombocytopenia or heparin-induced thrombocytopenia is a 50% decrease in platelets over a 5-day period. So let's say you start out with 200,000 platelets and 3 days later you're down to 75,000 platelets. That is, by definition, heparin-induced thrombocytopenia. And then we would do some tests to see if it was just happenstance that your platelets dropped while you were on heparin, or if in fact you do have this autoimmune disease called heparin-induced thrombocytopenia. So what labs do we monitor with heparin? Well, we're going to do a CBC. We're going to make sure that the platelet count remains normal while people are on heparin. But the test that we use to monitor the effectiveness of heparin and to make sure that we're in the right therapeutic range is a test called the PTT, or the APTT for automated prothrombin time. Okay? PTT is the test that we use to monitor heparin and the anticoagulation effects, but we also need to throw in an occasional CBC while patients are on heparin. All right. So the indications for heparin are treatment and prophylaxis. So treatment means that we're going to anticoagulate people therapeutically and keep their blood anticoagulated for the entire time. Prophylaxis, to prevent blood clot formation, we use a lower dose, and sometimes we just give it sub-Q to prevent blood clot from forming. All right. So again, active clot, we use therapeutic dosing of heparin, and to prevent blood clots like DVT, for instance, we use a prophylactic dose. So VTE prophylaxis is just as easy as 5,000 units of heparin sub-Q every 8 to 12 hours. Treatment of thromboembolism is IV heparin, and we usually just put IV heparin on a protocol. All right. There's also a chance, particularly in some other parts of the world, where we just use intermittent boluses, you know, of 3,000 or 5,000 units every few hours IV. So the contraindications and cautions are heparin-induced thrombocytopenia, anybody who's hemorrhaging, who's had recent major surgery, severe liver disease. Why liver disease? Well, because the liver actually makes clotting factors. And if your liver isn't making clotting factors because your liver's broken, then you might not need to be anticoagulated. In fact, in severe liver failure, we monitor the pro time, the PT, to know how severe your liver failure is. That's just a little side note. All right. Long-term use of heparin can result in osteoporosis, so we don't use it long-term. It is safe in pregnancy, but there are other agents that we use as well. Okay. So the problem with IV heparin is that that big molecule makes it really hard to, and the protein binding, by the way, make it really hard for us to regulate somebody's PTT. Well, guess what? Through the miracle of modern science, some guys in a lab figured out that we could take just one part of that giant heparin molecule and just take this tiny little pretty molecule that's easy to regulate and give that. We can know what the effects of that little tiny pretty molecule will be based on the patient's weight. We don't have to do any other daily laboratory tests. We do not monitor the PTT when somebody's on low molecular weight heparin because we don't have to. We just know that it's working, and we know that you're therapeutically or prophylactically anticoagulated based on that weight-based dose. The labs that we do are just one, and that's a regular CBC, because although we don't have to monitor the PTT, we do still see some heparin-induced thrombocytopenia with this in patients who have that side effect. Okay, so now I want you to know that when you see a patient and you're giving Lovenox, for instance, or enoxaparin is the drug name, when you're giving enoxaparin and you're giving 1 milligram per kilogram every 12 hours sub-Q, that is a therapeutic anticoagulation dose. That means that they're anticoagulated, blood cannot clot easily, and we're doing that because they have an active clot somewhere. Okay? The prophylactic dose is either 30 milligrams twice daily or 40 milligrams once daily, depending on the study, depending on the patient population, and whether it's a surgical population or a medically vulnerable population or a joint replacement population. The prophylactic dose is much, much less than 1 milligram per kilogram every 12 hours. Okay? So again, the laboratory tests, we do not do the PTT, but we do a platelet count every few days while people are on this. Okay? Lovenox or enoxaparin is the one that we use commonly. You can see this patient here has been getting Lovenox injections in the belly. This is not the stomach, by the way. This is one of my little things. I want you to learn this terminology. This is not your stomach. This is the patient's abdomen. The stomach lives up here and holds food, right? The stomach is an organ. This is an abdomen. And so this patient was getting injections in her abdomen with this Lovenox stuff, and that's why that bruising has taken place. So the indications are the same as heparin. Remember, a prophylactic dose is 30 milligrams sub-Q twice daily or 40 milligrams sub-Q daily. The therapeutic dose is 1 milligram per kilogram sub-Q twice daily in adults. Contraindications and cautions are similar to heparin. There's also a risk of spinal and epidural hematoma when somebody's using Lovenox. So, you know, we're careful to avoid those situations. Okay? So, I was watching an interview with this guy named Thomas Scalia, who's the chief of trauma surgery at Shock Trauma in Baltimore. And he was talking to some residents, and he said to them, there's 5 places you can bleed to death. And I love this. 5 places you can lose enough blood that you actually can die from it. So think about this. If you, I have had a lot of students say that that bleeding into the brain is one place that you can lose enough blood to die from. Well, that's not actually true. Remember, the brain is in a box, and so bleeding just a little bit into there increases the pressure so much that you know you could die from intracerebral hemorrhage and only lose 20 cc's or 50 cc's of blood into there. Not enough to exsanguinate and lose all of your blood volume. But these are the places you can bleed to death. Your extremities, your chest, you can lose a lot of blood there, in the abdomen and the retroperitoneal space. There's a easy ability to lose a ton of blood in the retroperitoneal space. And my favorite one was the street. And what he was saying is that, people who are untreated in the street often die from their from shock because they are unable to generate a blood pressure, etc. So that was just a little fun thing I heard and wanted to share with you. So now we've talked about IV and sub-Q anticoagulants. Those are heparin and low molecular weight heparin. Those are used for short-term anticoagulation. We've also talked about antiplatelet agents, but we're not talking about them now. We're done talking about antiplatelet agents. We're just talking about anticoagulants. So we have Lovenox and heparin that you can give in the hospital during the acute phase. But what are we going to send patients home on? Well, you can't send them home on heparin because they get, what was that problem? They get osteoporosis from it, osteopenia. So we have something else up our sleeve, and that is warfarin. Now, whenever you talk to a farmer or somebody who's been around the block for a while and you mention warfarin, they immediately think of the warfarin that they buy to control rats and that is the same stuff. It is rat poison. Now, we use it in a little different way, but it is the same stuff that poisons rats and makes them bleed to death. We use it at a therapeutic level, and we call it COUMADIN. So the mechanism of action, unimportant. It's factor 2, 7, 9, 42, hike, I don't know. But they are the vitamin K dependent clotting factors. So this is the opposite of vitamin K. Did you even know there was such a thing as vitamin K? Well, there is. And it's absorbed in the gut, and you get it from green leafy vegetables like kale. Who doesn't love kale, right? So this medicine has the opposite effect of vitamin K, and that's how it works. The good thing about it being a vitamin K analog is that to reverse COUMADIN, we give vitamin K, and that fixes it, but it takes a long time. Warfarin is also very highly protein bound, and this is the thing that we see in clinical practice all the time. If you work in a physician's office, particularly in a cardiology practice where we deal with COUMADIN day in and day out ad nauseum, you'll have patients who are on a steady therapeutic anticoagulation regimen with warfarin, and then something happens, they get sick, they have to get put on an antibiotic, and suddenly now their INR is 10 and they're out of control. Well, that's because of this whole protein binding thing that we talked about. They're on the warfarin, they have achieved steady state, and there's a certain amount of warfarin that's attached to the albumin molecules in the blood, and the blood can't hold, the albumin can't hold any more warfarin, so any extra warfarin that's not attached to the protein is now biologically active, floating around in the blood. Now we add an antibiotic, and I'm not going to disparage any antibiotics by telling you which ones, but we add an antibiotic, and now that is also protein bound, so it competes for protein binding with warfarin, kicks off some of the warfarin from the albumin in the blood, and now there's a lot more warfarin biologically available in the blood, and that means the patient becomes supra therapeutic. Their blood is way over anticoagulated, and they're at risk for bleeding problems. So we see that all the time, and we hate it, but it's what we do. All right. The other little thing that you should know about warfarin, this could end up on a certain exam that you will be taking in just a couple of months, not to mention the one that you'll be taking next week, but sometimes, well, every time, we give the medicine in the evening. And the reason is that when the patient is at home and they're going to get their blood test in the morning, we would like to be able to change their dose of COUMADIN that day and not have to wait. But if they've already taken their dose before they go and get their blood drawn, then we can't change their dose until the next day. So by convention, patients take COUMADIN in the evening sometime so that we can get back in touch with them and tell them what changes to make. So what lab tests do we monitor for warfarin? Well, we don't have to worry about the platelets because we don't have that same heparin-induced thrombocytopenia thing. But the lab test that we monitor for warfarin is the pro time, or the prothrombin time, the PT. Okay? So warfarin sodium comes in a whole bunch of different dosages: 1, 2, 2.5, 3, 4, 5, 6, 7.5, and 10 milligram pills. And the dosage varies a lot. Some patients are on 1 milligram a day. Some patients are on 10 milligrams a day, but the average patient is on somewhere between 2.5 and 5 milligrams a day. And sometimes it's 2 milligrams, 2.5 milligrams for 3 days, and then 5 milligrams on Mondays and Sundays, or Mondays and Fridays, something like that. We regulate them based on their blood tests. The indication is for long-term anticoagulation. The blood test that's available when we start patients is for first dose over responders. So let me explain that. Occasionally, we put patients on COUMADIN or WARFARIN, and they have this dramatic effect, and their blood is super anticoagulated from the first dose. Well, it's not actually anticoagulated, but it looks like it is. Their pro time and their INR go through the roof. So what do we have to do? Well, we have to know that they're going to be these super responders. And the way to do that is to do a lab test that tells us patients who are likely to be super responders so we can adjust their COUMADIN dose effectively. To be honest, we don't do that test very often, but there are some places that do it. I have not seen that done very often. We often take our chances with it and deal with the consequences if we need to. The half-life of warfarin is about 20 to 60 hours. That means that for most patients, the dose of COUMADIN that you take today will become effective 2 days from now. Not tomorrow, but the day after. And so it takes a while to get these things regulated and figure out what's what. So just remind your patients that it takes an awful long time for the dose that they take today to become effective. Okay? Some nursing considerations are listed here. Higher risk of major bleeding. We have patients who are on warfarin for long periods of time, and suddenly they come in with a GI bleed, and then we start the whole workup for GI bleed. It's particularly harmful, or particularly worrisome, I should say, in elderly patients and those who are deconditioned. They may need reduced dosages as well, but the whole goal is to maintain their INR, their international normalized ratio, which is a function of the pro time. It's to maintain that PT and INR at a specific level. So the INR that we usually aim for is 2 to 3. Between 2 and 3. If you have a mechanical mitral valve, for instance, those people are really at high risk for stroke. So those patients we maintain at 2.5 to 3.5 INR. And there's some other people who we try to keep their anticoagulation even thinner than 2 to 3, other than those patients. So one of the lies that I learned in nursing school was to tell patients not to eat foods that are high in vitamin K. Well, when you think about it, how dumb is that, right? It makes no sense that we would tell patients not to eat green leafy vegetables. I mean, can you imagine telling a patient, don't eat vitamin K foods? Well, what's in what foods is vitamin K in? Oh, all the good stuff. The vegetables. Don't eat vegetables anymore. I can't imagine anybody saying that. But we tell patients that all the time. A better thing to tell them is to eat the same amount of vitamin K rich foods every day. Don't have an all kale Friday. Eat about the same amounts throughout the week, so that we have a consistent dosing of your warfarin. Okay, does that make sense? So I would spend some time on this slide, understand what high and medium vitamin K rich foods are, and some supplements that may affect warfarin as well. So now we're going to talk about direct thrombin inhibitors and novel oral anticoagulants, or NOACs. So with warfarin, remember we talked about heparin and how it's a big ugly molecule and it's hard to regulate and we have to take lab tests all the time and it's a pain in the neck. So we came out with Lovenox, or low molecular weight heparin, where we don't have to monitor a blood test except for the CBC, and it just works, right? Based on the weight. Well, the same thing happened with warfarin. Warfarin's a big, ugly molecule. It's a pain in the neck to regulate. Patients have trouble maintaining their normal anticoagulation on it. So wouldn't it be magical if we had a drug that we could just give them based on their weight and we knew that it was going to have the effect that we wanted? Well, that's exactly what they did with these NOACs, or the novel oral anticoagulants. And so instead of this big, ugly fibrinogen thing that gets attached to thrombin and fibrin forms, we can just give a smaller molecule that we know exactly how it works and have the same exact anticoagulation effect that we can predict from one person to the next. It's very convenient. We use it for non-valvular atrial fibrillation. Essentially, that just means people who don't have mitral stenosis. That's really what that means. It sounds fancy though. Non-valvular atrial fibrillation. Well, whatever. It just means they have AFib that's not from mitral stenosis. Not mitral regurgitation, that's okay. We use it for MR all the time. But mitral stenosis is a no-no. Okay? Treatment and prophylaxis against DVT also. This slide is a little old. It says that it's not reversible. There actually is, within the past year, and actually less than that, just a couple of months, there is now on the market a agent to reverse PRADAXA in this case, or DABIGATRAN. And we to be honest, we don't really use it because this medicine wears off within 24 hours, which is more than I can say for warfarin. That stuff sticks around forever. So we don't really, I've never actually had to give the reversal agent for PRADAXA. I don't even remember what it's called. How do you like that? Now, the important thing here is, what lab do we monitor? The answer is none. We don't have to monitor the ProTime and INR because it's meaningless. It may be elevated, it may not be, who knows? The patient is still anticoagulated, and we know that because this is a weight-based dose. All right, so it's indicated for stroke prophylaxis and atrial fibrillation, and also treatment of active VTE. There are other ones out there. There's Eliquis, and there's, Xarelto, and all the other ones that you hear on the TV, followed by a lawyer commercial saying, if you've been injured by PRADAXA, call us. But anyway, the medicine that we're going to learn as the novel oral anticoagulant agent is PRADAXA, or dabigatran. Simple flat dosing, no regular blood tests, but it's expensive. It's about $450 a month, and that can be expensive. This particular drug is 150 milligrams twice a day. There is Xarelto that is once a day, taken at dinner. But this medicine, this was the first one on the market. The potential reactions are severe GI and other bleeding, thrombocytopenia, increased risk of thrombotic event if it's discontinued before the completion of therapy for, say, DVT. There's also a spinal epidural hematoma risk, so we have to make sure that we take that into account and select our patients for those procedures correctly. This requires a dosage adjustment in renal failure because it is excreted through the kidneys, and we don't want people to be over anticoagulated. People are immediately and completely anticoagulated after the first dose, and I can't say that for warfarin. And this is one of the better things about this medicine. Okay. So do we use a NOAC or do we use warfarin? Well, it really comes down, and by the way, I had a patient yesterday in the hospital that I had to make this decision with. So this is a guy who is very conservative Mennonite. They don't have health insurance. He pays cash for everything. In fact, he has an implanted ICD, an implantable cardioverter defibrillator, and they wanted $80,000 to implant that at a local hospital. He searched all over the country and found a hospital in Wichita, Kansas that would do it for $32,000. So he went to Wichita to have his ICD put in. And now I met him yesterday because he gets admitted to the hospital with ventricular tachycardia. Oh, and by the way, he also has atrial flutter, so we need to anticoagulate you. So I can give you these two choices. I can put you on warfarin, in which case you're going to be getting blood tests perhaps every week, but hopefully, once a month. And it's pretty cheap. Or I can give you a much more convenient drug where you don't have to get your blood tested at all. I just have you take a pill once a day or twice a day, and I know you're anticoagulated. So it's a really hard decision, and he made a very calculated choice based on the fact that he assumed that he was going to need lots of blood tests, and he didn't want that hassle. And so this gentleman actually decided to go with a novel oral anticoagulant, and discharged him today, and hopefully he'll do very well. So last thing I want to talk about is thrombolytic agents. So who needs thrombolytic agents? Well, not many people anymore, to be honest with you. We went through the heyday in the 90s with thrombolytic agents for acute MI, until we did enough studies that we learned that patients really do better when they get a coronary angiogram and stent or angioplasty or whatever right away, rather than going through the formality of giving thrombolytics first. Well, what do? They dissolve the blood clot. Actually, that's not really true. What they do is they prevent more clot from accumulating, and that allows the body's own tissue to dissolve the blood clot. So let's say it that way. They prevent further aggregation of the clot and allow the body's tissue plasminogen activator to dissolve the clot. So it's sometimes used in acute MI when the cath lab is not immediately available. We see it used in very remote places that don't have a hospital within 2 hours. And when I was at the American College of Cardiology meeting last weekend, they showed a slide, and I think only like 5% of the entire country is not within or I should say 5% of the population of the country is not within 2 hours, probably by helicopter, of a facility that can take you right to the cath lab and do an angioplasty. So very, very few people would probably have a need for TPA anymore. But some of the people who do are people who have a stroke. And so we use it for thrombotic strokes pretty frequently. It's also possible to use it for massive pulmonary embolism where the patient is in extremis and dying and not doing well. But the place that we use the most nowadays is really when patients have permanent catheters in their chest, like a Broviac or a Hickman or something like that. If that line becomes clogged or clotted, we can give thrombolytics that will dissolve that clot and make that device usable again. So there are essentially 3 different thrombolytic agents. They're urokinase, streptokinase, and tissue plasminogen activator, the brand name being Activase. They bind to fibrin and dissolve the clot. And streptokinase and TPA are the ones that are usually given systemically in acute MI or stroke. The issue with streptokinase was that you could only get it once. Not that you'd want it more than once, but when you give streptokinase a second time, a significant number of people have anaphylaxis on subsequent exposures. One last thing is that when you give thrombolytic agents for an MI, you have to follow them up with heparin to prevent more blood clot from forming where that clot was. That is not the case in treatment of CVA. We don't want to poison your clotting factor so much that you're likely to bleed into your brain. So we do not routinely give IV heparin with the thrombolysis of CVAs. So, how the heck am I supposed to remember all that? Well, conveniently, I gave you this one slide that summarizes everything that you probably could have skipped the lecture to learn. But here it is. Antiplatelet agents. There are 3 different receptors that those antiplatelet agents can connect to. One is commonly for aspirin, one is for PLAVIX, and one is for integralin. The GP2B, ADP, thromboxane A2, that stuff doesn't matter. The important thing is that you know that aspirin, PLAVIX, and integralin are all antiplatelet agents that prevent the platelets from grouping together. They are not anticoagulants. They are not blood thinners. They are antiplatelet agents. The blood test that we do for monitoring them is nothing. We don't have a blood test for antiplatelet agents. Next, anticoagulants we use for acute treatment like DVT, for instance. And we would use heparin in the hospital, or Lovenox, which is more expensive, but we don't have to check all the blood tests. We only have to monitor platelets. With heparin, it's a big, ugly molecule. It's hard to manage, but it's cheap. We just have to check PTT and platelets frequently. For chronic treatment, send patients home on these, we would use warfarin or the novel oral anticoagulants. Warfarin is hard to manage, but it's cheap. We just have to monitor the ProTime and INR. For NOACs, it's easy to manage, but it's expensive. And there are no labs for us to monitor with those. And then finally, we have thrombolytics. These are the clot busters that help the body to resorb intravascular clots. And that is what you need to know about saber-toothed tiger injuries. All right,